The SNRIs, the selective serotonin norepinephrine reuptake inhibitors, these agents, venlafaxine, desvenlafaxine, and duloxetine, they block the reuptake of both norepinephrine and serotonin. But they are pretty well tolerated in that they don't have a lot of antimuscarinic or antihistamine effects. Uh, and they're pretty well tolerated. You will see the same kind of things you'll see GI intolerance that you saw with the SSRIs. You will see withdrawal syndrome similar to the SSRIs. The other thing to think about is there is this talk about serotonin syndrome we'll talk about, or something that looks like serotonin syndrome, what we alluded to earlier, neuroleptic malignant syndrome. And my sense is it's probably more serotonergic, but the norepinephrine could be an issue here as well. So you worry about any muscle rigidity with folks on one of these agents. And we'll again talk about that in a couple of minutes. Other issues are that these drugs, particularly duloxetine is sort of an interesting drug in that it is a little more antimuscarinic, but it also has some data for neuropathic pain. Some of the other tricyclic antidepressants do as well, but duloxetine is probably a great choice for a patient who has depression in conjunction with neuropathic pain, which is true. A lot of folks who have neuropathic pain have concurrent depression. And for these folks, duloxetine might be a reasonably good choice that kind of deals with that. Similarly, patients with fibromyalgia or chronic musculoskeletal pain, lower back pain, often those folks will also have a concurrent sense of, gee, the pain isn't in good control. There's a sense of hopelessness and depression related to that. And duloxetine has a moderately good track record there. So, I don't want to raise expectations that these are cure-all drugs. They're not. But they do offer sort of, they're worth a trial and to work with a patient to find the best fit based on all of their symptoms and what one agent in a group may have a subtle advantage over another for a particular patient. Venlafaxine, pretty commonly used. Historically, I think I used to only see venlafaxine used by the behavioral health experts, psychiatry. But I'm seeing more and more venlafaxine being prescribed by primary care as well. Venlafaxine is a very interesting drug in that at low doses it behaves mostly in serotonin. At moderate doses has more norepinephrine uptake, and at high doses affects dopamine as well as norepinephrine and serotonin. So we usually start at a low dose, but if a low dose of venlafaxine doesn't work and the patient's tolerating it pretty well, we might consider a slight increase in dosing. We do keep an eye with a slow going up on venlafaxine, though, because patients will, like with the other SSRIs and SNRIs, nausea and GI complaints. You can see some sense in some patients getting a little more anxious or nervous with these and have some sleep disturbances. So you want to sort of keep your eye out for that. And that's probably related to the norepinephrine reuptake as well. And similarly, duloxetine used for both depression and neuropathic pain, and in higher doses, even generalized anxiety disorders. And you'll find that many of these agents may be helpful in anxiety states, and we'll kind of differentiate in a bit which ones are good for anxiety states and which ones sort of can make anxiety worse. The other commonly used agents, more, I guess I'd sort of group these as the atypical agents, but are commonly used, and they have some similar mechanisms, are trazodone, bupropion, and mirtazapine. Trazodone affects serotonin, and it affects serotonin type 2A receptor. It's pretty sedating. And so in practice, trazodone is commonly used as an add-on therapy for sedation in a patient who has insomnia, either with or without depression. So in older patients in particular, where we want to avoid the anti-muscarinic properties of Benadryl, that we want to avoid benzodiazepines with changes in impairing memory, trazodone as a choice for insomnia is become really the first-line therapy for the majority of patients with insomnia who are candidates for drug therapy. But when we come back and talk about sleep disorders and insomnia, you got to get to the root of why a patient has insomnia. Is it depression, for which Well, trazodone may help with their depression, but not really a great first line for depression, so to treat their depression. Is there insomnia because they have sleep apnea for which they should get a sleep study and then be evaluated if they're candidates for CPAP and weight loss and all the other things you're going to do there. Okay, so trazodone, primarily we consider it as a low dose for insomnia and not really as an antidepressant per se very often. Bupropion is a very interesting drug. Bupropion blocks dopamine and norepinephrine. And the benefits are that it helps with smoking cessation and it's associated with no sexual dysfunction for almost everyone. And in fact, may actually improve sexual dysfunction in patients who have a problem with it. So on occasion, you might even find someone who has sexual dysfunction to an SSRI or an SNRI who get added a little bit of bupropion to that mix. But here are the downsides to bupropion. Despite the fact that it helps with smoking cessation and it has no sexual dysfunction, it has a high risk for seizures. So patients who have seizure risk, it's an issue. And because of its norepinephrine effect, causes in about half of patients insomnia or anxiety, irritability. It gets them a little wired. And that can be problematic because a lot of patients who have depression have concurrent anxiety, and bupropion would not be a good choice for them. So important again to get the matches right. Mirtazapine is an interesting drug, and mirtazapine, pretty highly sedating, but the advantages it has, it causes an increase in weight gain and appetite, and I see clinicians sometimes reach for mirtazapine carefully, but reach for it maybe with guidance from psychiatry in a patient who has severe depression associated with significant weight loss. So it has a niche and a role. I think we worry a little bit more about some of the other side effects of mirtazapine as well, maybe bone marrow suppression and maybe autonomic nervous system responses as well. So we'll talk about those in a bit. So with bupropion, as we sort of refresh our memory of what we just noted affects norepinephrine and dopamine, not serotonin, good for smoking cessation, but a big issue with patients with a seizure history. Other patients who have a seizure history or you worry about not wanting to use this are folks who have a problem with alcohol and could go into alcohol withdrawal seizures. So patients who have a history of alcoholism, bupropion, not a great choice. And patients who have a history of anxiety or insomnia, again, probably not a great choice. Advantages, smoking cessation, no sexual dysfunction. Disadvantages, seizures, anxiety. Trazodone, highly sedating. Most often what you'll see is a low dose of 50 or 100 milligrams for sleep. For depression, higher doses up to 200 or 300 milligrams sometimes used. The other issue I didn't mention about trazodone, it's rare, but in younger men can risk priapism, which may need a urologic surgical intervention to correct. And so that's sometimes a concern with trazodone. Particularly, I'd be concerned about that with a phosphodiesterase inhibitor like Viagra or something like that, where the combination, at least in theory, its effect on serotonin could be more dire. But again, kind of a rare event. And mirtazapine, sort of mixed effects, but the weight gain and sedation sometimes render mirtazapine a consideration in some patients who have weight loss as part of their presentation for anxiety. Here's a chart that kind of looks at the sort of comparing these sort of agents and where they kind of fit. Let's briefly talk about St. John's wort that's been around as a natural alternative product for a long time and probably in popular culture in North American popular culture, probably for the last 20 or 30 years. There's some data that St. John's wort is associated with managing mild depression, and it acts as a mild MAO inhibitor. But as a clinician goes, there are a lot of concerns for St. John's wort. The data is equivocal. You'll find some studies that say it works really well, and then others that will say it doesn't do any better than placebo or anything in between. And truth be told, for some of the antidepressants, you could probably find similar data as well. Um, the things we don't really know about St. John's wort is the degree to which its action would produce significant drug interactions. We know that with other antidepressants, particularly in some other drugs, there are associated drug interactions with them. And so we want to be careful about that. Really, most importantly, I think, is to suggest for a patient who has mild depression who wants to try St. John's wort to kind of do it carefully if they're going to do it, but to consider looking at all the potential interactions they could have with other drugs. And if they're not getting the response they would expect, to sort of work with you on considering alternatives to St. John's wort. But in the same token, with all of these therapies, as we alluded to earlier, counseling, psychotherapy, mindfulness, exercise, light therapy, all of these things sort of go hand in hand. And again, I think if you look at studies about St. John's wort versus SSRIs or other agents and placebos, if you want to find a study that demonstrates benefit, you'll find it. If you want to find a study that demonstrates it does nothing, you'll find that too. So I think you'll find that there's varying responses to many of these sort of modalities, and a lot of it has to do with methodology of the older studies. But I use this old study to sort of remind us that patients will sort of put stock in something, and some of the methodology may be a little dated. The newer antidepressants, in my mind, I have less experience with the agents we're going to talk about here, and I am a believer in using things that we've had more experience with safety and efficacy than going to the newer therapy. But I'll defer some of these. I'll give you some inkling to some of these newer therapies, some of the specifics of them. I'll just keep in mind that many of these are not going to be covered by an insurer as a first line. They might need a prior auth, and they're usually, in my mind, going to be reserved for patients who are refractory to standard sort of therapies we've already talked about. So here's the first, a newer SNRI agent, Fetzima, which early studies suggest some benefit. Adverse effects are, similar to, I think, what we normally would expect. And dosing with some drug interactions also noted here. So in my mind, not a lot here to say this is, better than some of the other modalities that are on board that you have already. Brintalec's another sort of what's considered a multimodal serotonin reuptake inhibitor. Interestingly, it affects different subsets of serotonin for major depression, and indicating that maybe efficacy is better at the higher doses. It's a 2D6 inhibitor. Here's the issue, that it might have these identified multimodal mechanisms. Maybe some of the SSRIs do as well. We just maybe don't know that. And just because something has a identified mechanism doesn't necessarily make it a safe or a more effective product. So I think that in my mind, the jury is in a sense out until we have a lot more data and head-to-head comparisons with standard therapies we have now, for which I think you'd be hard-pressed to find sort of robust studies suggesting that. The adverse effect profile is similar to what you would expect to see for many of the other SSRIs and SNRI agents. And here's some sort of comparative data for sort of dosing in comparison. All right, let's talk a little bit about some issues when you're thinking about, as a clinician, okay, which antidepressant do I pick? I've got all of these in my toolbox. We've alluded to some of the benefits and downsides of the different antidepressants that are on the market. So let's look at some published data that over the last decade or so that kind of helps guide sort of which agents are becoming or have become more first line for which patients in which situations. Because there's a lot of drugs out there. And I think we kind of go with, well, if we have a good track record of safety and efficacy, clinicians often will have their first or second pick agents based on what their experience is. So I'm going to give you my sort of off the cuff what I see. But I will tell you that I am not working in behavioral health. So I can't tell you that I see this and do this day in and day out. Um, but kind of what I see from patients coming in the hospital, what I see here matches what I see. So in 2009, there was sort of an intriguing study. Now, keep in mind, this is a 10-year-old study now, but they looked at uh, multiple studies and meta-analyses comparing efficacy to the extent that they could. And what they found is that certain agents sort of floated to the top as being more efficacious. And those were mirtazapine, escitalopram, venlafaxine, and sertraline. And so I will say that what I see clinicians use and reach for are escitalopram as probably the most common one I see. I see a fair amount of sertraline and venlafaxine, and I see mirtazapine typically in the older patient, low dose, who's refractory to other things and has had weight loss, and you want some weight gain and a little sedation. That matches what I see clinicians doing as far as their first choices or the more common agents I'll see patients on. This 2016 uh, analysis that was underway and is ongoing is going to look at some of the questions that were addressed in that earlier study from 2009, comparing efficacy and to some degree acceptability and safety of these agents. So expect that long-term, these longitudinal assessments are going on. A 2017 study looked at the surrogate outcome of brain-derived neurotropic factor. And suggesting that some agents differ in this compared to others. Now, I'm very skeptical when I see data like this because it's a surrogate marker that doesn't necessarily mean it's correlated with something clinically meaningful. But it is suggestive that there is a biologically derived substance which may or may not be correlated with management of depression and augmenting of the symptoms of depression. But I don't put a lot of stock in this. This study indicated that most of the major agents would offer some improvement in this marker, but there might be variation in some over others. Here, a 2013 study did look at the genetic variation and the role of genetics in determining which antidepressant is effective, and we clearly know there is a genetic variation in response. This 2014 study done in Korea looked at response rates that their genetic profile was correlated with an improved likelihood of response to one agent over another. And so I think it's important to look at that with genetic information in this cohort they looked at, there was a correlation and better prediction based on this genetic marker who was going to respond to therapy and who was not. I think in this day and age, though, that the genetic testing isn't quite at the level where that predictive analysis internationally is a standard of care. But I think the answer clearly is to ask that question of a first-degree relative who may have had depression. Have they tried different antidepressants? If so, has any been more successful than another? And consider that as your first-line choice. But keep your ear to the ground. The degree to which genetic testing in the management of depression will become more mainstream, covered by whatever healthcare plan the patient is under, and provide us as clinicians better tools to predict who's going to respond to which agent. I think this study that was published a number of years ago, but is sort of reflective of the multiple expanding indications for the SSRIs in particular in this line, but the SNRIs as well. Where we see not only depression, but we see the timeline for when some of these agents were used for other conditions than depression, for obsessive compulsive disorder, for bulimia, for panic disorder, for social phobias and anxiety states, for generalized anxiety disorder, for post-traumatic stress disorder, all of these sort of situations where some of these agents have a little bit better track record. And so some of the subtleties of the benefit, particularly the anxiety states correlated either with or without depression, the SSRIs and to some degree the SNRIs offer some clear sort of benefit in treating these states either in addition or in place of patients with depression. There are sort of different ways that we look at all the indications for some of the SNRIs, SSRIs, or tricyclics, and you'll find that there are sort of different sort of indications for different agents used. And you can look at this graphic, and I take this with a giant grain of salt because I don't think that this data set from GoodRx can determine this as readily as they think they can. But I think the reason I want to share this is to recognize that these antidepressants are often used for things other than depression, and I think you'll see that they have some beneficial track record in these other conditions, particularly in anxiety states, obsessive compulsive disorder, and other conditions as well, pain management to some degree. With seasonal affective disorder, there's a lot of data as far as the benefit of light therapy. And so I think for folks who do have seasonal affective disorder, anything they can do to improve their access to light, be it walks in winter, whether it's a bank of lighting, whether it is just to change the daylight spectrum of light bulbs they use when they're inside, those all make sense. There are two or three different sort of data that's been available for which antidepressants help with seasonal affective disorder. There's some data for bupropion, just watch out for seizure risk, particularly at 300 milligrams a day. There's been some data for some of the other agents that may or may not have had benefit with anxiety, with SSRIs like fluoxetine. In combination with or in place of light therapy. But I think what this sort of says to me, sort of in pretty uncertain terms, is that if someone has seasonal affective disorder, exercise and light sort of will go hand in hand in improving symptoms. And to the degree to which when you assess light therapy, particularly if you're asking people to go outside and walk in winter, in daytime, is it the light that's affecting them, particularly if they live in an area where there's a lot of reflective light from snow? Is it the light that's helpful, or is it the exercise that's helpful, or likely it's probably both? So, you kind of want to think of all the non-drug things you can do to help patients really sort of take control of their lives and take control of their depression and do all the right things and encourage them to do these kind of lifestyle changes. Adherence to therapy is often troublesome, and sometimes the barriers patients may have is not understanding depression, or unfortunately, still, there's a stigma for depression, particularly in some cultures or in some families where the depression stigma is more pronounced. And it's important to kind of speak in a very matter-of-fact kind of tone. And I think once you get into practice, you'll recognize how ubiquitous depression is, how common it is in patients. And you'll be able to kind of help patients just understand this is, you're not alone, that this is so many people have depression. And I think in the age of COVID and the tumultuous sort of year that 2020 has been for so many people, that we have also situations or situational depression and anxiety that sort of layer on top of the underlying depression and anxiety. And in those circumstances, doing all the lifestyle things on top of maybe a safer choice SSRI or maybe an SNRI may make sense in situations where the lifestyle things and the counseling things and the exercise and light and all of that don't really kind of quite do enough. So just consider all of these things, but to do it as an empathetic caregiver is really important.